Hi, I'm Arun Singh. I'm from the UCLA sarcoma program, and I'm here to talk about some of the approved treatments for GIST today. I wanted to thank Barbara and Bartos for inviting me to give this talk today, and most of all, I want to thank all the patients for taking the time to come out and hear about these treatments. Dr. Albert just talked about the history of surgery for GIST tumors. I'm going to focus more on the history of the development of targeted therapies for GIST. GIST can be broken down into two main categories, whether they're resectable or unresectable. Dr. Albert went over the management of surgery for GIST patients, and now that has evolved to involve giving therapy before or after surgery. I'm going to talk mostly about GIST as unresectable or is metastatic. As you know, the history of therapy for GIST in the past, chemotherapy is just not effective for this disease with less than 5% response rate. Radiation therapy can be used, but it can only be used for certain localized therapies. Most of the talk will focus on the developments in GIST since 2001, and before 2001 we know very well that there were no really good therapies for GIST. And what really brought about this change and led us to the point today where we know to use Gleevec, regorafenib, sorafenib, Sutent. You know, everybody in here knows all of those names. Everybody knows about exon 11 and exon 9 mutations, and but how do we get to this point? And I think a lot of the talk today will be focused on reviewing the history of how we've come to this point. The slide today shows one of the first well-documented cases of a patient responding to Gleevec. And so this was in 2001 between a Finnish group and a group in Boston. The slide here shows a patient with metastatic GIST to the liver, and as you can see, the hazy areas are in the different metastases to the liver. And after 1 month of treatment, we can see that these metastases have actually become quite much darker, and in fact that represents the tumors dying from inside, becoming more and more cystic. And lastly, in panel C, we see that this is after a few months of treatment that most of the tumors have involuted, and the largest tumor reflected here actually is much smaller and much more cystic than before. And this was published in the New England Journal in 2001. So what did that group recognize, and what led them to picking Gleevec for this disease? And so we reflect back on as Dr. Albert mentioned, in the late 90s, a Japanese and a Finnish group identified KIT as a marker of this disease. So for the first time, you had a molecular way to identify a specific type of disease. And so the name of this protein was KIT. And moreover, people recognized that it's not just that you had this protein marker in GIST, but in fact you had a whole series of mutations that really defined the disease. And identified here is the KIT protein. This is the extracellular part, this is the cellular membrane, and this is the intracellular part of the protein with the concomitant mutations at the different locations on KIT. So what that, in other words, what that indicates is in a normal case you have an inactive protein. This is a normal case that binds to a growth factor, and this leads to normal cell division. But in a cancer case, this is a case of the receptor. This is an example of KIT, but then you have a mutation. What ends up happening is this is basically, it's like a light switch is flicked on, and this is currently in an on state, and it tells the cell to divide continuously, hence the development of cancer. And this is just another depiction of how an oncogenic mutation drives a tumor. Today, the scenario is a little bit more complicated. We know not only that there are about 80% of the mutations in GIST are in the KIT protein, but probably another 10 to 15% are in PDGFR alpha, and then the remaining 10% is in our quote-unquote wild-type GIST. But of course, there's actually quite a few specific mutations, including BRAF. We just heard about a patient with a BRAF mutation, RAS, NF1, and succinate dehydrogenase B and C, which are really what makes up the quote-unquote wild-type GIST. So these observations led to a group of people running a clinical trial in 2002. They took up 147 patients and gave them 400 or 600 milligrams of Gleevec. And again, this is a time when we did not know of what the actual dose of Gleevec should be. And again, these were in patients who had metastatic or unresectable tumors. And so let me show you the highlights of this. The findings was that almost 50% of people, whether you got 400 or 600 milligrams of Gleevec, responded to the drug. What the response means is you actually had tumor shrinkage, and another 25 to 30% of patients had stable disease. And in this disease, stable disease is a good thing in that patients can have quite a high volume of disease, but if you keep it from growing any further, many people live quite a good life without significant side effects, besides the side effects to the medications. Of note, there's a small percentage of people who at the start of treatment are actually already resistant to these therapies, so that should be beared in mind as well. This shows how well people did overall and how long treatment responded continued in these original sets of patients. Other studies have attempted to figure out what is the correct dose of Gleevec. And in the first study, they compared 400 to 600 milligrams of Gleevec. But other studies, including this large data set, looked at 400 versus 800 milligrams. And as you can see, the two curves basically mirror each other. Furthermore, people have broken this down by mutation status. As you can see here, people who have exon 9 mutation seem to benefit more with 800 milligrams of Gleevec as compared to 400, but people without exon 9 mutations, the dose does not seem to matter, and as such, 400 milligrams is the dose we use today. Again, this is something called progression-free survival, that is how long a patient goes without their disease progressing, and then an overall survival basically mimics the data we learned from the exon 9 mutation and dosing. This is a slightly different question. How do you respond depending on what genotype you have? That is, if you have genotype X, what is the chance of you actually responding? So this shows again that exon 11 is most likely to respond, and most patients will respond within 1 year. But it can take some patients an entire year to respond. And you can see similar data for exon 9 and 11. A question comes up is how do patients with wild type GIST, that is GIST without an identifiable mutation, respond or do overall, and in general that seems to be intermediate between the exon 9 and exon 11 mutations. We talked about how chemotherapy is not effective, and as you can see here, doxorubicin historically has performs quite poorly in comparison to Gleevec. I'm jumping to another question, but that was in the setting of metastatic and locally advanced disease. But another question comes up after surgery: should you get Gleevec, and if so, how long should you get the Gleevec for? So, initially there was data that showed 1 year of Gleevec was beneficial. And then recently a trial was run in about 400 patients, splitting them up to receive 1 year of Gleevec or 3 years of Gleevec. And as you can see here, the chance of recurrence is much higher if you have 12 months of Gleevec versus 36 months. And similarly, survival is actually quite improved for people who receive 3 years versus 1 year of Gleevec. The one good thing, what you can notice here is after 1 year after the 12 months of Gleevec, there's a rapid fall off of the curve, indicating people are progressing. Luckily for these patients, most of these patients do respond to Gleevec. But then the natural question is 3 years long enough? And so currently people are looking at 5 years versus 3 years. But this data was published in 2012, and you won't know the answer for hopefully this year or next year. And based on this data, in February 2012, the FDA widened the approval for Gleevec to indicate that it can be used for 3 years after surgery. And for most of these patients, most of the cases we've talked about, we automatically assume everyone's getting Gleevec. But a more important question is, should everyone get Gleevec? And so there are tools we use to identify who should or should not get a Gleevec. And this is basically the same slide that Dr. Albert showed. And so this is a risk assessment tool based on the location of the tumor, the mitotic rate, and the size of the tumor. But we also use mutational data to help guide our treatments. So resistance, Dr. Tomilowski will talk more about resistance, but about 5% of patients have primary resistance and about 14% have early resistance, but he will talk more about these. This is a rather busy slide, but one question is, after Gleevec, what other treatments could you use? And first of all, I'm going to talk a little bit about Sutent. As you can see from this diagram, that the receptor tyrosine kinase, with c-KIT is one, signals through a variety of other proteins in your body, including RAS, RAF, MEK, and ERK. And these are like billiard balls, and you have a chain reaction that's set off. Sutent not only blocks KIT, but it blocks PDGFR as well. So a study was based on this data. People were looking at for other second-line treatments after patients had failed Gleevec, and they randomized 312 patients in 2-to-1 randomization, and they were nice enough to allow patients who failed Sutent, who were on placebo, to receive Sutent thereafter. And as you can see, Sutent radically outperformed placebo. While it shows here that some of the placebo patients had stable disease, the stable disease is actually very short-lived, on the order of 6 weeks, whereas people on Sutent receive about 7 months of benefit. And then the third-line drug that actually came out, most people used to think sorafenib was a third-line drug, but actually there was no FDA approval for sorafenib. It was being used off-label. And so Pfizer decided to run a trial of regorafenib in the third-line setting, that is people who have failed Gleevec and Sutent. You can see in the diagram here, it's both sorafenib, Nexavar, and regorafenib, otherwise known as Stivarga, are actually almost the similar molecule. The only difference is that there's a fluorine substituted for a hydrogen at this position. And in reality, these are probably function very similarly. And as you can imagine, the company excluded patients who have received sorafenib from being on this trial. As you can see here, regorafenib also blocks PDGFR and c-KIT, also blocks RAF as well, which is a downstream signaling molecule. And here they also randomized patients into 2-to-1 placebo to regorafenib, and allowed crossover from the placebo to receive regorafenib. And it was clear that regorafenib outperformed placebo by nearly 4 months. In this case, people who started on placebo actually still had a median progression-free survival. That is how long your disease goes before growing, similar to the regorafenib group. So patients did well on that. And today, these are the NCCN guidelines that list the medications that they would recommend for GIST, including Gleevec, Sutent, and regorafenib. But you can see there's a few other methods. Sorafenib is here, nilotinib. Nilotinib is used for a disease called chronic myelogenous leukemia, and dasatinib specifically for patients with this rare mutation of the PDGFR alpha. But sarcoma and GIST are very rare things, and we're up here talking, but in actuality, your care is actually manifest by a large group of people who constitute the UCLA sarcoma program. As you can see, the pathologists, Scott Nelson, Sarah Dreyer, extremely important in one, figuring out the diagnosis and helping us find the mutational status. I can't tell you how many patients come in here without mutation testing, without the mitoses being counted properly. Dr. Kamrava is our radiation oncologist, and people for kids with GIST, Noah Fetterman is our pediatric sarcoma doctor. And so on any given case, this whole group of people helps to define the treatment. So thank you.